Two-stage implantologists still admire the surface of the implant and say that rough surface is like the best that could ever happen on the implant. Is it actually true?
No, of course it's not true. Look, in the field of traumatology, nobody believes that the surface of let's say, a fracture plate or a trauma device or anything has any influence on the survival or on the stability or something like this of the implant. Nobody believes it. So if let's say the dentist talks to traumatologists and says, look, we have this selective surface from Straumann, it's the best in the world, the traumatologist thinks this guy is crazy. You know, of course it's not true. Of course it's not true. What? Is too straightforward answer? and also, sorry, I want to mention one more point. No, the osseointegration was invented by Mr. Brennemark. I mean, he observed it the first time, osseointegration, in the 70s of last century, I don't know, 50 years ago. And he worked with polished implants. So the implants were machined, polished, and they also integrated. So it's simply not true. It's also what the universities claim today, that you must have a rough surface so you get also integration. I mean, it was from the beginning not true. It was never true. And only some university assistant professors who also want to give a lecture and they know something, blah, blah. They come up with this rubbish. It's of course not true. It's the rough surfaces may have a small advantage in the very beginning when the blood clot is on the implant, and this blood clot is kind of fixated then to the rough surface. But this mini advantage is really, I don't know how many mini should be before the word advantage, is paid by a big disadvantage over time, because these rough surfaces in the end make perimplantitis and they lead to the loss of the implant. And this should be really told to every patient. The patient should go and ask the implantologist not to give him these fancy surfaces, because simply they don't want it, they don't need it, and they are only dangerous. They are really only dangerous.
How does multi-steps implantation for masticatory function restoration, I mean when we just insert the implants and we wait until it heals and then we just load it with this prosthetics, right? How does it actually affect the result of this restoration?
What effect?
I mean, is it really good? I mean, is it okay to have all these steps with all this long periods, or maybe this about this loading, that we postpone this loading to the period while it's healed?
You mean good in the sense of, do we get a better quality at the end? Mm-hmm. No, of course not. I mean, look, if we put the strategic implant, we put it in the bone, it's fixated, mm-hmm. We put the bridge, and that's it. I mean, it's done. There's no point to wait. Why we wait?
And if we wait, for example, this two-stage implants, right?
Uh-huh.
Does it actually affect in a bad way the bone actually?
Look, this is like we drive a Porsche. Okay, somebody drives a Porsche, and the other one buys a highly fancy modern car and it drives only 20 kilometers an hour. And then they say, look, it's only 20. I know it's very slow, but you know, this is my quality of life and I can look out of the window and I feel it's environmentally and blah, blah. You know, this is simply people who prefer a car who drives 20 to the Porsche, they are, in my view, crazy. I mean, either you drive a car, then you want a proper car, you want to speed, you want to enjoy, you know. Nobody wants today this Gogomobile and then I wait 1.5 years until I get my teeth. This is not normal. I don't know why patients don't make revolution. I mean, they simply have to run away from all these doctors. Who does it?
Okay. Thank you. I think that we covered more questions that we want to do.
Always at your disposal.
Yeah, thank you.